Once we've defined the scope of our problem, we then move to determining how we're going to calculate the AUC. Do we want to use first order, two-level PK, like Tom talked about, equation-based dosing using an Excel calculator, or do we want to use a Bayesian-based platform? If we go the equation-based route using Excel, who has the expertise to program and manage this? If we want to follow the new guidelines to the letter, our preference would then be to use Bayesian-based methods. In addition to some of the advantages of Bayesian-based methods that Tom had highlighted previously, you also have the advantage of more advanced modeling, potential to have EHR integration for improved workflows, and you really get some more flexibility around your level timing. You have to consider which program will be most cost-effective based on what models you're interested in. Some Bayesian-based platforms will offer different models or how many users you may have. For example, if you're rolling this software out to all of your clinicians, or are you just rolling this out to select group? For example, if your institution has a per pharmacy dosing protocol, maybe you need a smaller group of users, such as just your pharmacists. And really, this was one of the key tables that we presented to our leadership in making a decision to Bayesian or not to Bayesian, if you will. So if we further compare the methods of first order pharmacokinetic AUC calculations, we see some additional advantages to Bayesian-based methods. Whereas our first order methods are fairly static, we have to extrapolate over various dosing intervals, or if we're changing dosing intervals, that becomes problematic. Bayesian methods are adaptive and predictive. Rather than requiring two levels to be drawn preferably at steady state, like with the first order equations, Bayesian-based methods can be drawn prior to steady state within the first 24 to 48 hours. There are some considerations around using one or two levels, which we'll discuss shortly. And with Bayesian methods, what matters most is the accurate recording of the level draw times and the dose administration times. As long as those deltas between those two variables can be accurately calculated, that level is considered valid from a Bayesian dosing standpoint. So if a peak is drawn late or a trough is drawn early, that's okay. Our Bayesian methods can adapt, whereas our first order equations require those precisely timed peaks and troughs. This with Bayesian dosing really allows you to have some more flexibility in your level of timing and schedule with other labs, such as morning labs, rather than requiring a separate stick.